Hi, I'm Dr. Suzanne Lippert. I'm one of the assistant clinical professors at the Stanford School of Medicine in the emergency department, and we are going to go through the altered mental status case discussion questions. So let's look at our first clip for case 1.
Charles Hadley, multiple wounds after a bar fight.
He passed out on the couch last night. This morning I couldn't wake him up.
Look at me, sir. Pupils equal at 4 millimeters.
You're right there, ma'am? Oh, it's nothing.
Well, we should take a look at it.
No, please, I'm all right, really.
CBC, chem panel, blood alcohol, C-spine, head and facial CT.
Dry blood at the left ear canal, positive battle sign.
Have a seat.
Chest is clear.
Abdomen soft, no rebound or guarding. Did he do this?
No. He didn't know what he was doing.
Are you saying your husband hit you, ma'am?
It was an accident. I was helping him down on the couch and he slipped. His elbow knocked me.
Pelvis is stable.
She's gonna need a facial series.
Okay, so just to summarize, we have a 50 to 60-year-old man who was in a bar fight last night. He passed out last night, and this morning his wife actually couldn't wake him up. Given this really brief history, what potential etiologies of altered mental status are you most concerned about? So you watched the attending in this clip actually check the patient's pupils first. Would you have started differently? And then what are you looking for when you are completing your pupillary exam? And how can you interpret your pupillary findings? So they also mentioned blood in the left ear canal and a positive battle sign. What do these findings raise concerns for in a patient with altered mental status? And here are a few pictures of what exactly they're describing. So at this point, what initial labs and imaging would you plan to complete immediately in this patient? Okay, let's move on to the next clip then.
Our party animal's more disoriented. Head CT shows basilar skull fracture.
Intracranial hemorrhage.
Got lucky there.
GCS is down from 14 to 8.
Mr. Hadley, open your eyes.
He's diaphoretic. Are the labs back yet?
Nope, not yet.
We need to repeat the head CT, see if there's a delayed bleed.
Sats dropping.
Okay, 100% non-rebreather.
Dr. Kovac, some guy called a couple of times, didn't leave a message.
You got a name, Frank?
He wouldn't say.
Okay, why are you telling me this, Frank?
Thought you'd want to know. It's probably a creditor.
Great, thank you. Thank you, Frank.
Doing an acu check?
He's not a diabetic.
No, but if he's a chronic alcoholic who's not eating, he might be hypoglycemic. There it is. Blood sugar's 34.
It's pretty low.
Amp of D50 and 100 mgs of thiamine. Yeah, I guess he's a bigger drinker than we thought.
It wasn't always this bad.
Advanced liver disease diminishes his glycogen stores.
His body can't respond to low blood sugar.
What the hell is going on?
Mr. Hadley, do you know where you are?
Chicago.
You're in the hospital.
When's the last time you had something to eat?
It's been a couple of days.
Guess I've been on a bit of a bender.
Cancel the CT.
Yeah.
Okay, again, to summarize, we have a CT confirmed basilar skull fracture, no intracranial hemorrhage on the CT, but he's now had a drop in his GCS from 14 to 8. He's also diaphoretic, and his oxygen saturation is dropping. So how would you begin your reevaluation of this patient? One of the attendings in the clip ordered a repeat head CT. Is this appropriate in this setting? Okay, now we're ready to move on to case 2. So let's start with our clip.
Abby, glad you could join us.
I got her as soon as I could.
Of course you did.
Says her name is Lois. She was staggering in a crosswalk before she passed out.
Is she drunk?
Nothing on the breath, no apparent head trauma. 150 over 90, normal sinus of 62.
You been partying, Lois? We got this one.
What do you got?
Manny Bonilla, male truck driver, swerved to avoid the lady.
Okay, to summarize case 2, we have a 30-year-old female who was found staggering in the crosswalk before she passed out. And you'll notice several providers ask, was she drunk? And the paramedics respond, well, there was nothing on the breath. She has no apparent head trauma, and her initial blood pressure is 150/90. She's in a normal sinus rhythm with a rate of 62. So let's begin with our first question again. This brief history raises concerns for which etiologies of altered mental status?
You're going to want 4 units of O-neg, a surgery consult, auto versus pole, abdominal and pelvic trauma. All right, on my count. 1, 2, 3.
Hi, I'm Dr. Morris.
Manny.
Trauma panel, C-spine, chest, and pelvis.
UA and 12 lead?
Yeah.
Can't believe this. 1 second, I'm driving along, minding my business, and there she is. Right in the middle of the street.
I got the hemo-Q. Scleral icterus. Braiding to 55.
Low heart rate. Is that why she fainted?
No, her BP's fine.
CBC, chem panel, type and hold, coags. Now, Frank, go through her stuff, see if there's any family to contact.
Kaya, do you appreciate the jaundice?
Hemo-Q 11.2.
How do we put it all together, altered and jaundice?
Maybe she has...
I didn't ask you, Laverne, do us a favor and put the patient in the gown.
Is it a head bleed?
No, there's no sign of trauma, but we do have asterixes.
Now, jaundice means liver disease, so what lab's going to help us?
AST.
No.
ALT? It's ammonia.
That's right, so she may have...
Hepatic encephalopathy from acute liver failure?
Very good, 45 cc's of oral lactulose.
You're quite the teacher.
Yeah, you should try it sometime.
Oh, I teach. I'm just very selective.
Okay, on their initial exam, they note that the patient has some scleral icterus, that she has jaundice, she's bradycardic to 55, but has a normal blood pressure, and she has asterixis. So they definitely, suggest that she actually has hepatic encephalopathy. You hear one of the med students offer that as a potential etiology of her altered mental status. What aspects of this patient's presentation are or aren't consistent with hepatic encephalopathy? They have initiated treatment with lactulose for her hepatic encephalopathy. Are there other critical actions that you would take at the same time or before initiating that treatment?
Picked up your toxicology sample.
Abby, Lois is vomiting blood. Suction's on high. Push the packed cells.
What's happening?
She's bleeding from either her esophagus or her stomach.
She had FFP?
2 units.
Okay, we'll call GI. We're going to head coagulate with an endoscope.
Right, hold on. Let's use recombinant factor 8A.
I don't know, it's a brand new drug.
It can normalize the PT in 20 minutes if the FFP fails.
Okay, gram rounds, your show.
4 mg per kg IV push.
Okay, and as we saw in this most recent clip, the patient is persistently altered, has signs of liver failure, but now also has large volume hematemesis. So there are multiple contributing factors to altered mental status in most cases. How could this GI hemorrhage contribute to this patient's altered mental status? We also see that this patient is quite dynamic, just as we saw in the last case. So what are the key points of reevaluation in this scenario with this altered patient who is now vomiting blood? Okay, so those are our questions for this series on altered mental status. Look forward to seeing you in the expert case discussion.